associated. Next thing is, that's what we discussed in detail yesterday. What are the pediatric physiological changes and how it is going to affect your anesthetic issues. And subsequently, we're going to discuss the remaining anesthetic challenges and then how to conduct anesthesia for this type of kids. Right. So this part is completed. Now let's move on to the associated problems. Right. So you should just tell me about what are the common syndromes associated with cleft lip and cleft palate.
Common syndromes, one is Prairie-Robinson syndrome.
Okay, it is not a syndrome, it is sequence. Okay.
Sequence.
Okay, why it is been changed from syndrome to sequence? It was previously called as Perry-Robin syndrome, but right now it is not called as Perry-Robin syndrome. It is called as Perry-Robin sequence. Why? No idea?
No idea, sir.
No worries. So it is basically the cleft lip and cleft palate is not an associated problem of Perry-Robin syndrome. The problem in the Perry-Robin syndrome is mandibular hyperplasia. So that causes micrognathia and retrognathia. So when there is micrognathia, what happens, during the developmental period, the tongue is pushed back because of the smaller mouth. So this pushed back tongue prevents the fusion of cleft palate or the palatal fusion mechanically. So failure to palatal fusion is not because of this any associated syndromes, but is mainly because of the micrognathia that is causing the tongue to get fall back, and that is preventing the fusion. And subsequently, all the problems happen because of this tongue being pushed back. Okay, so it's a sequence. So small mouth pushing back the tongue, that prevents the failure of maxillary and the frontonasal processes, and that eventually results in cleft palate. So cleft palate is not a direct cause of Perry-Robin syndrome. So that is why it has been changed from syndrome as a Perry-Robin sequence. Okay.
Okay,
Good. So Perry-Robin sequence then.
Second is Treacher-Collins syndrome, sir.
Treacher-Collins syndrome. Yeah.
Then Golden-Hanner syndrome.
Golden-Hanner syndrome.
Velocardiofacial syndrome.
Velocardiofacial syndrome.
Down syndrome.
Down. Okay, then there are Klippel-Feil, Stickler, so many symptoms are there. Nearly 200 to 300 syndromes are associated with cleft lip and cleft palate. But the most important are these three, right? Okay, just remember the clinical features of these three syndromes alone so that it might be useful. Rest all factors need not worry about, okay? So what are the primary problems in the Perry-Robin sequence? What are the abnormalities in the Perry-Robin sequence?
So one is they have associated cleft palate.
Okay.
Second, they have micrognathia.
Okay.
Third,
so they have micrognathia, retrognathia, and glossoptosis that eventually results in cleft palate. Okay. Okay, that's the main problem in Perry-Robin sequence. And what is the unique picture of difficult airway in Perry-Robin sequence?
Sir, they have easy to intubate, difficult to intubate, sir, because of small mouth.
Okay.
And post-operative respiratory complications are more for.
No. That's something different. So these kids, at birth, they have a very difficult intubation as well as mask ventilation because of micrognathia. But as the kid grows, okay, as a mandibular grows as a part of skeletal growth, they become a more easy airway compared to at birth. All right. So the difficult airway tends to improve as the kid grows because of the growth of the mandible. Whereas when you compare to Treacher-Collins and the Golden-Hanner syndrome, they are predominantly associated with maxillary hyperplasia. It's not a mandibular, it is a maxillary hyperplasia. So in maxillary hyperplasia, as a kid grows, the intubation is going to be more and more difficult. All right. So that's a major difference between the Perry-Robin sequence and these two syndromes, right? Of course, there are other associated problems, microtia, clefts, and so many things are there. Just read those things and memorize those things in these two syndromes, okay? But one thing I want to remember you is these two syndromes tend to have difficult airway as a kid grows, whereas Perry-Robin sequence, intubation becomes more easy as a kid grows, okay? Okay. Good. What are some of the non-syndromic associations of cleft lip and cleft palate?
One is fetal alcohol syndrome, sir.
No, non-syndromic association means cleft lip which can be associated with other problems but not coming in as a syndrome. That is non-syndromic association.
Vector anomalies, sir.
Okay, vector anomalies, fine. And the Vacher, right? Congenital heart disease. So these can get associated with cleft palate, but which are not a part of a syndromes. Okay, mental retardation, right? Spine abnormalities, then digital abnormalities, right? So these are some of the non-syndromic associations of cleft lip and cleft palate. So when you're assessing the patient, the kid for cleft palate or cleft lip surgery, you have to look for both syndromic problems as well as the non-syndromic problems. Okay.
Yes, sir.
So only if you know that cleft lip and cleft palate are associated with this type of problems, you're going to look for, right? So during your assessment and history taking, make sure you look for all these features, both clinically as well as examine them for any silent evidence of having these problems. All right.
Yes, sir.
Okay. Then what are the complications of cleft lip, cleft palate? We have seen syndromes and associations. What are cleft lip and cleft palate complications you're going to look for and treat them? One thing is they have chronic
Upper
rhinorrhea.
chronic
Chronic
rhinorrhea.
rhinorrhea, right? So chronic, regular, frequent respiratory tract infection. So how significant it is for the anesthetist?
Sir, during induction, there is chance of child having laryngospasm if
Okay,
there is a
so
relative.
they could have a stomy induction. The incidence of laryngospasm, bronchospasm is going to be extremely high if the baby is suffering from an active infection. Okay, so how do you, if the baby is coming with a running nose, with a fever, and a productive cough, which is of thick secretion, will you proceed for surgery or not?
No, sir. I would start an antibiotic and I will do the surgery. Postpone the surgery for another 3 weeks.
Another 3 weeks. Is it okay? Is it how do you decide your postponing duration? What is the
Depending
primary
upon
fact?
sir, depending upon the clinical features of the child, sir, there should not be any fever. There should not be any wet cough. There should not be any running nose.
Is that so? Right. No. So basically, if the baby is having running nose, no fever, active and alert, not lethargic, you can proceed for surgery. Okay, you need not wait. So these things are quite common. If you wait for these things, you can't do the surgery. Okay, the pediatric patients tend to have 6 to 8 upper respiratory tract infection per year normally without any problem. So when you have these problems, which means there is no any active inflammation running in there, right? When you have these problems, you can proceed without waiting for anything. Whereas when you have a high fever, a lethargic kid, non-feeding kid, when there is thick secretions or colored sputum and lethargic, when these problems are there, wait. Okay. And if there is any active wheeze. So depending upon the presence of wheeze, you're going to differentiate. It is going to be an upper respiratory tract infection or a lower respiratory tract infection, depending upon whether the lung is clear or not. So if it is an upper respiratory tract infection, how long you can wait?
3 to 6 weeks, sir.
No. If it is just an upper respiratory tract infection, you start them in antibiotics, complete the course of antibiotics, and then you can proceed after 1 to 2 weeks. Okay. So
Okay, sir.
1 to 2 weeks after the completion of antibiotic course. That is more important, not after the infection. Okay.
Yes.
So after the completion of antibiotic course, take 1 to 2 weeks for upper respiratory tract infection. If there is a wheeze or any lung abnormal, additional sounds in the lungs, it indicates a lower respiratory tract infection. In that case, wait for 3 to 4 weeks. So 1 to 2 weeks in URI, 3 to 4 weeks in lower respiratory tract infection. Got it?
Yes.
Which means not from the date of onset of infection, from the date of completion of antibiotic course. Okay, that is what is more important, right? So start antibiotics, count the date, wait for 1 to 2 weeks, make sure clinically they're improving. And as I said, make sure these problems are not there, which are pathognomonic of having intraoperative complications like laryngospasm, bronchospasm, desaturation, all these things. Okay,
Yes, sir.
right. So chronic rhinorrhea. What are the product complications of cleft lip which can be an issue for the challenge for the anesthetist?
Sir, low, not adequate weight due
Yeah.
to
So
that
when
they
the
should.
baby is anemic, right? So
Yes, sir.
because of poor nutritional deficiencies, right? The babies tend to be anemic because of poor feeding intake. So what
Yes.
is the rule of 10 when you take this type of kids for surgery?
Uh, Rule of 10 means weight of 10 pounds,
10 pounds,
HB of 10 grams per deciliter,
hemoglobin 10 grams,
age of less than 10 weeks,
less than 10 weeks or more than 10 weeks?
more than 10 weeks, sir.
More
More
than
than
10
10
weeks.
weeks.
And
Um,
one more.
TLC less than
Yeah,
10,000.
total leukocyte count less than
Total
10 10.
leukocyte count less than 10,000.
10,000 total leukocyte count. So this is rule of 10 being followed. Okay. So make sure the baby's hemoglobin is at least 10. Why it is given so much importance in the pediatrics and not in adults of hemoglobin of 10? In adults, we can take even at the hemoglobin of 8, right? But why
Yes.
pediatrics are more concerned about hemoglobin of 10 grams?
The oxygen carrying capacity, mm,
Think of that's why physiology is more
they have,
important.
yes, they have more fetal hemoglobin.
Fetal hemoglobin becomes adult hemoglobin at what age?
I'm not sure, sir.
By 6 months. Okay, by six
Yes,
months
sir.
the entire fetal hemoglobin is replaced by adult hemoglobin. Okay, so
Yes.
that doesn't matter now. But why hemoglobin of 10 grams is given so much importance?
Intravascular volume is more.
Now again, revisit your physiology we discussed yesterday. So 50% of anesthesia practice is only physiology, pharmacology, and physics. Okay, if you know all these things, you can be the best anesthetist in the world. So physiology is so important for the anesthetist. Again, I'm stressing. Okay, physiology is very important for the anesthetist. So why hemoglobin of 10 grams is given so much importance? Because these babies, as we discussed yesterday, pediatric patients tend to have high oxygen demand, right? Because of their high metabolic rate. When the demand is more, you need an adequate amount of hemoglobin to match that demand, right? Right. Whatever the amount of oxygen you gave, it is going to be only in the dissolved format unless the hemoglobin is in a good state. So that is why 8 gamma hemoglobin will not be sufficient to maintain the oxygen demand of the kid. So these kids, pediatric patients tend to have high oxygen demand. So that is why you have to maintain a hemoglobin of minimum 10 grams before proceeding for surgery, right?
Yes.
Good. So this is one other problems of cleft lip and cleft palate. Next is anemia. What is the other problem? When the baby is giving an history of snoring or apnea during feeds, what are the things which comes in your mind?
Um, that there's more chance of desaturation during induction.
No,
And
no. When a baby is giving a history of snoring during assessment or clinical history taking, what are the things which has to come in your mind when you're doing your, what are the anesthetic challenges which is the main problem for you? So
Post
that's
op
why we ask this
obstructive
history.
sleep apnea, sir.
Okay,
Post-operative
so
apnea.
obstructive sleep apnea, so they are very sensitive to sedatives. Okay, so you can't give too much amount of sedatives like opiates or midazolam to as a pre-medication or as a part of analgesia. So we should be very precautious in prescribing them sedative medications. Then other importance of snoring during apnea or feeding.
More chance of post-operative apnea, sir.
Okay, anything else? Chronic hypoxemia, right? Okay, so
Yes.
obstructive sleep apnea history of snoring produce chronic hypoxemia, which eventually results in right heart failure. Okay, so that is
Yes.
another important feature when you ask for a history of snoring in your history and examination. Okay, that's why you ask history of snoring and apnea during feeds. When the mother gives history of snoring, you have to look for the features of right heart failure and make sure it is not present actively in the kid. Okay, so these are the problems, major problems, which can present along with the cleft palate, secondary to this congenital deformity. So one is associated syndromes, some of the non-syndromic associations. Second thing is the cleft palate itself can cause so many problems in the kid. And these are the problems which are going to produce a significant anesthetic challenge for you. Right.
Okay, sir.
Is that clear?
Yes, sir.
Good. Now let's move on to next one. Difficult airway, right? So how do you assess the airway? Airway assessment is going to be extremely difficult in a 4 months kid because you can't ask kid to open the mouth or look into the Malamberti score or nothing. So
Yes.
without that, how could you predict a difficult airway in this type of kids?
Presence of facial dysmorphism, sir.
Okay, predictors of difficult airway in cleft lip and cleft palate. What is the first thing you told me?
Facial dysmorphism, sir.
Facial dysmorphism. Okay, then
Um,
when there is large alveolar cleft. Okay, when there is bilateral cleft lip or cleft palate. Okay, when there is retrognathia or micrognathia. When they are associated with syndromes like Perry-Robin or Trichocrolin. And lastly, age less than 6 months. All right. So
yes.
these are the predictors of difficult airway in a patient with cleft lip or cleft palate, and you have to look for these predictors of difficult airway. If these things are present, you have to prepare for your airway management adequately. Got the point?
Yes, sir.
So these are the predictors of difficult mask ventilation as well as difficult intubation. All right. So facial dysmorphism, large alveolar clefts, bilateral cleft lip or cleft palate, particularly bilateral cleft with the premaxillary issue. Next thing is when the baby is having retrognathia or micrognathia, which might be non-syndromic or syndromic, and lastly, age less than 6 months. When these factors are present, definitely there is a chances of having a difficult intubation scenario in your operation theater. Okay, understood, doc?
Yes, sir.
Okay, right. Now we have spoke about the difficult airway and difficult predictors of difficult airway. Let's move on to the next anesthetic challenge, which is going to be the shared airway. Right. So, what is the issue of shared airway?
Accidental one is when they put that gag, uh, uh, that retractor, there is chance of the tube getting kinked.
Okay, so when they share the airway, the surgeon doesn't bother about our tube; they're bothered about only those equipments. So the tube can get dislodged.
You can
All
get
right,
kinked,
tube can get misplaced. You can get kinking.
bleeding.
You can get extubation, accidental extubation. You can get airway trauma and bleeding. You can get tongue swelling because of the equipment, the mouth gag they use,
Yes, sir.
right? And then anything else, the shared airway, you don't have access.
Access to.
No access to the airway once they drape the surgical field. So these are the challenges when the airway is shared between the surgeon and anesthetist. So you should be very, very vigilant in positioning after putting the mouth gag and all those stuff. All right. So
Yes.
risk of post-operative complication, we'll discuss the post-operative thing when it comes. So these are the anesthetic challenges which you're gonna face when you are anesthetizing this type of kids. All right, we discussed everything. Now let's discuss about the goals of anesthesia. What are the anesthetic goals you're gonna aim for?
Adequately pre-medicate the baby.
No, that is not a goal. Proper planning for intubation, right? Then a bloodless field, maintaining adequate depth, because when you are operating in the airway, the chances of light plane is very high. So maintaining adequate depth of anesthesia. Then smooth extubation. Then adequate analgesia without respiratory depression. Then preparation for postoperative complications. Right?
Okay, sir.
So these are the anesthetic goals, and you have to plan your anesthetic management targeting this goal so that it runs smoothly. All right. So challenges are different, goals are going to be different. Okay. So challenges is the one which you're gonna prepare. Goals are the one you're gonna target for. Okay. So proper planning for intubation, provide a bloodless feel for the surgeon, maintain adequate depth, have the plan for smooth extubation, adequate analgesia in such a way that doesn't compromise the respiratory system, and eventually preparedness for the postoperative complications. So these are the goals of anesthesia management. Okay.
Okay.
Now let's move on to conduction of anesthesia. Right. So what are the things before proceeding for anesthesia you do?
Um,
Tell,
Pre-anesthetic.
tell what you do regularly in your practice. That's what they expect. So only when you tell what you do regularly, they'll understand that you are doing it in a proper way. Okay. If you tell for the exam's sake, you tend to miss things. Tell what you do normally and regularly. I
I'll
can fine
see.
tune.
I'll do a I'll start from the day from the pre-anesthetic checkup, sir.
Yes. So pre-anesthetic assessment. That's the first part of anesthesia, right? So pre-anesthetic assessment. What do you do in the pre-anesthetic assessment?
In pre-anesthetic assessment, I will look for any active respiratory tract infection.
Okay, so you're gonna history and examination. You're gonna look for the anesthetic challenges we're gonna discuss, right? So what is the any predictors of difficult airway? Any active problems associated with the cleft palate, like we discussed, like chronic rhinorrhea, right heart failure, anemia, all right. Right. So this are the comes in the history and examination. What do you do next in the preoperative assessment?
Next, I will write about the NPO orders.
Okay, fine. So what are the NPO guidelines for pediatric patient?
That is 1 hour prior to clear fluids can be given 1 hour prior to the up to 1 hour prior to the surgery.
Is it 1 hour or 2 hour?
1 to 2 hours.
I
1 to
think
2
it's
hours.
I think it's 2 hours in majority of the guidelines.
2 hours. ASA
Yeah,
guideline.
it's 2 hours, I think. So it's 2 hours for clear fluids. So if the baby is on breastfeeding, breast milk,
Can
it's going to
have
be
4 hours.
4 hours. Formula feeds,
Formula feeds 6 hours.
6 hours.
Or solids if it is also
Solid food going to
solid
be 8 hours.
8 hours.
All right. So this is the fasting guidelines. Okay. Pre-anesthetic assessment, history and examination has been done. If there is any active infection, you're going to start him on antibiotics. You're going to postpone depending upon the type of infection. Right. So history examination done. Fasting guidelines you have done. What is the next?
Pre-medication orders, sir.
Pre-medication. Does pre-medication is indicated in all these kids?
Sir, if syndromic child below 8 months, pre-medication is not
Not needed.
needed.
Why? Why
Mm,
pre-medication is not needed below 8 months?
No separation anxiety.
There is no separation anxiety. Exactly. Okay. These babies, kids don't cry when they separate from the mother. Okay. So pre-medication is not a key issue in this type of kids. Okay. Right. So pre-medication depending upon the age. So what are the pre-medication prescribed? What are pre-medications to be avoided? What are the best pre-medication to be given?
Benzodiazepines like midazolam can be given.
Can I give pre-medication benzodiazepine in this type of kids? Particularly when there is risk of snoring or apnea in the history.
So if there is no anomaly, associated anomaly, we can give benzodiazepines. Otherwise, we can give ketamine, sir.
Okay, ketamine. Ketamine. How do you give ketamine?
Ketamine can be given per orally and can be given IV.
Okay, fine. You can give oral ketamine, or intramuscular ketamine or intravenous ketamine. Fine. So any other pre-medication? There are a lot of studies running on this drug. Very, very effective pre-medicating age.
Dexmedetomidine.
Dexmed. Okay, Dexmed, right? So dexmedetomidine has been hopefully over the next 5-10 years is going to be a regular part of pediatric pre-medication. So intranasal Dexmed, The main advantage is it separates the baby from the mother smoothly. IV cannulation is baby is going to be very cooperative. And next thing is it is not a respiratory depressant. Okay. So these are the so many advantages of giving a Dexmed pre-medication. Okay, Dexmed, if you tell in the exam, it's well and good. So these are pre-medications you can try, and make sure the baby doesn't have. Don't give benzodiazepines. The patient is having a risk of snoring or apnea in your history and examination. Fine. So before proceeding for pre-medication, you do investigate the kid, right?
Yes, sir.
That's why I said do go in an orderly way so that you don't miss anything. What investigations you look for?
I would look for a complete blood count. In
Complete
that, I
blood
would
count.
look for a
You're going to look for
hemoglobin.
hemoglobin and total leukocyte count and the
Hemoglobin.
reasons we discussed already. Then what investigations you do?
Then I would do an ECG, echo,
ECG, echo, chest X-ray.
chest X-ray.
What are the indications for these three?
Chest X-ray to rule out any lower respiratory tract infection.
Do you need this kid needs chest X-ray?
This kid doesn't need a chest X-ray.
Okay, so then what is the need for doing these three things? When do you do these things?
When there is a cardiac anomaly,
Okay, when you suspect
cardiac.
any syndromes, right? When you suspect any syndromes, when there is clinical evidence of infection. Okay, only then you're gonna do all this investigations. Otherwise, CBC and urine electrolytes. That is all sufficient, right? If the baby is nutritionally depleted, okay, in your history and examination, you can look for serum electrolytes. All right. Otherwise, complete CBC and urine examination is all that's sufficient. Serum electrolytes are concentrated only when the baby is clinically dehydrated or when there is a nutritional depletion. All right. Then blood grouping, typing, and cross matching.
Yes, sir.
When do you do these things? For this surgery, is it indicated?
For cleft palate, usually we need to arrange blood, sir. For cleft lip, usually it won't.
For isolated cleft lip, it doesn't need any transfusion. But when they are doing a revision cleft lip surgery or when they're going for cleft palate repair, you're gonna need blood grouping, typing, and cross matching. Okay. Right. So you have done all the investigations. Baby is adequately prepared as per your history. The baby had an infection 4 weeks back, and the antibiotic course is completed. Now it is ready for induction and anesthesia management. Right. So let's move on to the theater. What do you do when the baby comes to the theater?
I would get the theater ready, keep the
Okay.
AC off, keep the temperature
What is the
above,
temperature you target?
sir, above 25 degree.
About 25 degree. Based upon what criteria you are choosing it to be 25 degree?
Mm.
What is meant by thermoneutral zone or neutral temperature zone? Have you heard of this thing?
No, sir.
Right. So thermoneutral zone is the temperature zone where the body's metabolism is at its minimum. All right. Where the oxygen consumption is at its minimum. Okay. So that is a thermoneutral zone. So for the premature kids, when you're operating on a premature unit, what is the target temperature you keep? The temperature. It is going to be 34. You have to keep the theater temperature above 34 degrees. When it is a neonate, what is the temperature you target? 28 degrees.
28,
For adults, you're going to keep 22.
20.
Right?
Yes.
So at these temperatures or above these temperatures, their oxygen consumption is at its minimal range. Okay. So these are the thermal neutral zones you have to concentrate when you fix the theater temperature. Okay. So preparation of theater comes the theater temperature. So this is a 4 months kid. So you can keep roughly between 28 to 30 degrees Celsius as a theater temperature. Good. Then
I'll keep warmer sheets ready.
okay, keep warm sheets ready. Just
Uh,
tell you what you do. That's it. Don't think of any complex things. Sell simple things. That's enough.
Keep standard monitors ready for pediatric.
Okay, standard ASA monitors ready.
AC monitors ready. I'll check the machine, keep the pediatric circuit ready.
Check the machine and get ready for the pediatric circuits. Then
I'll get a pediatric scope, tube.
Okay. In simple terms, difficult airway equipments, right?
Yes, sir.
All the difficult airway equipments, right? Get ready. Anything else? Fluids.
Yes, fluids and adequate number of cannulas.
Okay, fluids and cannulas. Keep it ready. So, what will be the fluid requirement of this kit?
According to Holiday Segar formula, sir,
Hmm.
this is a 4 kg child.
Okay.
I would for 40 ml per hour, sir.
40 ml per hour. Are you sure? This is a 4 kg, right?
Yes, sir.
So, what is the holiday cigar formula?
For first 10 kg, sir, it is 4 ml per kg.
Okay, then how much ml does it
16,
come?
16,
16,
16
right?
ml. Yes, sir.
Okay. So, it's going to be 16 ml. Of which 8 ml is the only thing you're going to give in the first 1 hour.
Yes,
Okay.
sir. Yes, sir.
So, which fluid is ideal fluid for pediatric patients?
Mm, plasma light or isolate P, sir.
Isolate P, or you can use ringer lactate, or you can use dextrose 1% with normal saline. So the best fluid, the best balancing fluid is ringer lactate plus 1% dextrose. This is an ideal fluid which is commercially not available, which you can prepare, or you can use ringer lactate, that is all sufficient, or you can use dextrose normal saline, half normal saline, a quart normal saline, or you can use isolate P for a maintenance fluid. All right. So this is ideal IV fluid for pediatric patients, and the fluid rate will be 8 ml per hour in the first 1 hour, and subsequent hour it's going to be 8 ml per hour along with the ongoing loss of the insensible water loss. Okay,
Yes, sir.
good. So right, so fluids, cannulas, everything is ready. Now the kid is coming inside.
Yes, sir. So if the baby is having an IV line, I would go for IV induction.
Okay, if the baby is not IV line, what do you do?
If the baby is not having an IV line, I would go for an inhalation induction, sir.
Okay, so IV induction and inhalational induction. What are the advantages and disadvantages of each?
IV induction, there is less chance of having uh, laryngospasm and smooth
Less
induction
chance
with IV.
of laryngospasm, smooth induction. Okay, then anything else in the IV? You can give muscle relaxant, right?
Yes, sir.
What are the advantages of doing an inhalation induction? I can tell the opposite of all these things. All right.
Yes, sir.
So chances of breath holding. Okay. Laryngospasm is more common when you use an irritable agent. Okay. Then because of inhalation agents, like when you use halothane, what happens? What the changes effect of halothane? They're going to go for
Yes,
significant bradyarrhythmias when you're going to use halothane, right?
yes, sir. Yes, sir.
So bradyarrhythmias, right? Then they're going to produce severe myocardial depression. So securing IV line can be difficult.
Yes, sir.
So when you don't secure IV line, you can't give muscle relaxant. It's going to be difficult to intubate. Okay. So when you have an IV line, IV induction is the best. But when you don't have an IV line, you're going to use inhalation induction. Try to secure IV line is very important. So once IV line is secured, you can convert them to IV anesthesia management. Okay.
Yes, sir.
So
Excuse
it's
me,
a
sir.
yeah.
If it is a difficult airway, isn't inhalational better?
I think it's again depends upon the clinical situation. Okay, so you have to do a smooth induction. Make sure you keep the spontaneous respiration intact all the time until you require an IV access. Okay, until you access an IV line. Okay, don't when you do an inhalation induction, don't put the baby to apnea. Okay, that's another key factor you have to have in mind. All right, so have a smooth induction, have a slow induction. Confirm the baby's spontaneous movement by the back movement all the time. So by the time the baby goes for a moderate to deep sedation, try to get an IV line at that point. Okay.
Sir, excuse me. Sir,
Yeah.
what are the different techniques of inhalation induction, sir?
What are the different effects?
techniques, sir. How do we do the
All right.
inhalation?
So there is no any standard recommended way that this has to be done. This is the way. This is good. This is bad. Okay. Everyone does in a different way. I'll tell you what I do. Right. So what I did before putting the baby for inhalation induction, I flush the circuit. I fill the circuit with 8 liters of oxygen along with 4% of the inhalation agent like CO or preferably I use CO here because that's halothane is not been used in majority of the places. But halothane is a wonderful inhalation agent for the pediatric patient. If you compare halothane and sevoflurane, halothane is the best. But of course, it has got its own complications. Majority of the centers now have sevoflurane. So I flush the circuit for 5 minutes with this type of combination. Okay. So once this is done, I keep the mask slowly with the kid, make the baby to make adequate attempts. Once the baby goes gets in that inhalation agents, you can look into the change of the respiratory pattern. Okay, so if they're breathing at a rate of 20 per minute initially, once the baby gets in this 8 liters of oxygen along with 4% sevoflurane, once they reach around 0.8 to 1 Mach, what they do, the respiratory rate becomes 28 to 30. They become more tachypnic. Okay, so that you can understand at that point that sevoflurane has reached the respiratory center. Okay, so that's a clinical evidence. So once you reach at that point, you can increase your sevoflurane to 7 to 8%. So by the time you increase the sevoflurane to higher level, okay, when you're making the baby more deep, that is the point, the crucial point, you have to get the IV access. Okay, so that is the point the baby will not move. So at that point, you have to both assist the breathing as well as trying to maintain the spontaneous attempt of the kid. Some people, they just straight away keep oxygen and they keep on increasing the CO at much time. But I've seen that when you do that type of technique, the baby tend to be very jittery and struggling to breathe. So this is technique I follow. As I said, there is no any standard way that this is the best way to do. Most important thing is flush the circuit, fill the circuit with sevoflurane before putting the mask onto the pediatric phase. Okay. So the point where the baby goes for tachypnea to apnea, that is a crucial point. You have to secure an IV line. So there will be a classical difference between the propofol induction and SIVO, right? So when you induce the babies with SIVO, what happens when the depth of anesthesia keep on increasing, they get more tachypnic and then they go for apnea. Whereas when you give a propofol induction, just before when they reach the adequate depth, there will be sudden increase in the depth of breathing. Okay, they'll breathe very high minute ventilation, and then they go for shallow breathing and go for apnea. This is a pattern with propofol and sevoflurane.
Okay, sir.
Okay, good. Where were we? So inhalation induction. Okay,
Yes,
right. Now you have induced a baby, you got an IV access. What do you do now? IV access is secured.
Then I will give muscle relaxant, sir.
Okay, preferably,
No
is it
deep.
enough? Would you give a dose of propofol for the baby?
Yes, sir. To deepen
Okay.
the
Once you get the IV access, give a dose of propofol. How much dose you give?
2 mg per kg, sir.
Okay, that's for adults. You have to give 3 to 4 milligram per kg because we discussed yesterday the volume of distribution is very high. So you need to give a high dose of propofol compared to adults, right? Preferably 3 to 4 milligrams per kg, right? So why
Yes.
do you give propofol? What is the advantage of giving propofol?
So once it deepens the plane of anesthesia.
Okay.
Second, the pharyngeal reflexes are lost.
Okay, mainly it blunts the reflexes. It's the most important thing. So the airway reflex are best blunted with propofol, right? So you give propofol, the baby is going to went in for apnea. What do you do next? Tell me what you do inside the OT. That's what we examiners expect you from. So
sir,
inhalation induction is done. IV is secured. Propofol is given. Baby is gone for apnea. Next.
I'll give if it is a complete laryngospasm, there won't be any chest movement. Then I will give.
So leave about the laryngospasm. It's laryngospasm or not, it's different, right? So propofol is given, apneic, baby is gone for apnea. What do you do next? That is a simple question. I didn't tell about any laryngospasm.
I'll give a muscle relaxant and then.
This is a key point, okay? At this point, they expect you a different word, not giving the muscle relaxant.
Cut
You
off
do
the
it, you do it regularly in the OT, but you're not telling me. That's a problem.
cut off the
Suction
inhalation.
the airway.
Not
Suction
necessary.
the-
Not necessary.
Check for
Not necessary.
adequate ventilation.
Yes, okay. Ventilate the baby and check for the movement of breathing, right? That's what you do, right?
Yes.
Yeah. So once the baby is going to apneic, you're going to ventilate and check the ventilatory status. This case is a difficult airway, remember, right?
sir.
So this is a difficult airway where you can have a difficult mask ventilation as well as difficult intubation. Hopefully, pediatric patients, the majority of the patients, they go for easy mask ventilation. The incidence of difficult mask ventilation is only 0.02%, even in cleft lip and cleft palate. Okay. So
Yes.
when you're dealing with a difficult airway case, once you give propofol, just inform the examiner that you're going to check the ventilatory status. When you don't tell that, it's going to reflect very badly, right? I know you do it, but you don't tell in the exam. That's why I'm stressing you to waiting you to get this word from your mouth. So check the ventilator status, mask ventilate a couple of breaths and check whether the chest is moving properly or not. And only then you're going to give the relaxant, okay? Without confirming the chest movement, no relaxant at all, all right?
Okay, sir.
Good. So you're ventilating, there is no chest raise. What do you do now?
I'll give a muscle relaxant, sir.
There is no chest raise. Would you give a muscle relaxant at that point?
No, sir.
I said propofol is induced, baby has gone for apnea, and you're trying to ventilate the baby is not ventilatable. What do you do next? This is how the exam questions will be. They will check you whether you are a safe anesthetist or not.
So
I'll
the
do
doctor,
manuals to check. Um,
See, Dr. Nishu, just tell me what do you do if you're facing in that situation? Don't tell for the exam's sake. Assume yourself you are in that situation, and what do you do regularly in that situation? That is what they expect from you.
cut off.
I'll put 100% oxygen, sir.
Okay, give 100% oxygen. Lovely, fine. Then
Suction the airway.
suction the airway, right? To look for any obstruction,
Any
any
obstruction.
aerosolization, right? Suction the airway. Then
Give a chin lift to.
okay, you can give a chin lift. You're gonna do airway manipulation, right? You're
Yes.
gonna give a chin lift, jaw
I'll
thrust.
give
Jaw
a
thrust.
positive. Yes, jaw thrust and
Okay,
keep
jaw thrust.
keep.
Jaw thrust and chin lift. Okay, you have done that. Then
Then I will keep some peeps, sir. Positive and expression. Put some peep and try to
it's
ventilate.
not a PEEP, it is CPAP. Okay, and I give a ventilate manually with the CPAP. Still no mask ventilation. What do you do?
Put in an airway and.
Okay, good. Okay, you're gonna put in an airway. So during airway insertion, be very careful because there is cleft. It can go and lock there, and it can produce accidental injury to the oral tissues, and it can bleed horribly. So you're gonna put an airway and ventilate, right? So still not ventilating. What do you do?
Nasal prongs, oxygenation.
No. Okay, you are given 100% oxygen. You have suctioned the airway. You have given jaw thrust, cleft lip. You are giving CPAP. It is not opening up. You have put an airway. It is not opening up. What is next?
Chest compressions.
You're gonna do two-hand technique. All right. See, do routinely what you do in the OT.
Okay.
When one-hand technique is not working, what are you gonna do? You're gonna do two-hand technique, right?
Yes, sir.
Okay, still not working. What do you do next?
Lawson's maneuver.
Larson's maneuver is not. What is the purpose you're gonna tell Larson's maneuver?
Leave laryngospasm.
Okay, there can be a laryngospasm. Okay, that's the most important thing they expect you from your mouth. Okay, so after doing all these maneuvers, if you feel that the baby is not able to ventilate, the next thing is the problem is not above the cords, the problem is cords and below the level of cords. Got it?
Yes, sir.
So when there is, these are the problems which will correct the problems which are above the cord, right?
Yes,
All
sir.
the things only will correct the problem when there is obstruction above the level of cords. These problems will not correct when there is obstruction at the level of cord or below the cords. So what is the most common reason for obstruction at the level of cords is going to be laryngospasm, right?
Yes, sir.
So when you suspect laryngospasm, what do you do?
We will try to break the laryngospasm by
Deepen the plane of anesthesia.
Okay, deepen the plane. Very simple. Deepen the plane. You're going to give another shot of propofol. Immediately give another 2 to 3 mils of propofol for this baby. Okay,
Yes, sir.
good. But if there is no laryngospasm, despite two-hand technique, there is no laryngospasm. If you still find difficult to ventilate, what do you do? Just think of what you do inside the OT. Jatras, chin lift, CPAP, airway, two-hand technique, still not working. What do you do? And laryngospasm is ruled out. Now you again propofol, laryngospasm is relieved, but still not ventilating.
Sir, bronchodilators, IV
No,
bronchodilators.
It's an acute situation. Baby is going to desaturate very fast, right? And the reason why they desaturate very fast, we discussed already yesterday.
Try to intubate.
No. Intubation is not a key factor. Oxygenation is very important all the time. Okay. Never try to intubate when you're not able to ventilate a kid because you're not given muscle relaxant so far. Simple thing. What is the difficult airway strategy, the protocol?
Mask ventilation. We'll continue with mask ventilation.
Okay. As I said, mask ventilation is not working. What do you do next?
LMA.
LMA, right. Put a supraglottic airway device. Okay.
Yes, sir.
You do it or not?
Yes, sir.
Yeah, when there is no laryngospasm, but all the airway maneuvers tend to have failed, what is the next choice? You're going to put the supraglottic airway device, okay?
Yes, sir.
That's the last resort of ventilating the kid.
Yes, sir.
So this type of questions you will get in the exam. So when you find difficulty in mask ventilating, either it is because of the tongue fall or the airway abnormality, or it could be because of the laryngospasm. When there is laryngospasm, you're going to give a dose of propofol or deepen the plane. When there is an airway obstruction, you have to do all these maneuvers. Additionally, in pediatric patients, particularly in this type of cases, you can put the baby in lateral position and ventilate.
Yes, sir.
This I forgot to mention, okay?
Yes.
So give CPAP, give Jatras, give chin lift, turn lateral, still not working, put an airway, still not working, two-hand technique, still not working, put an LMA.
Excuse me,
Understand?
sir.
Yes,
Yeah.
sir.
How is this going to help lateral?
Lateral position is going to pull the tongue forward away from the obstruction, right?
Yes, sir.
Thank you.
Right, because in supine position, it's because of the gravity it is falling down.
Yes, sir.
Okay,
Yes, sir.
right. So you're ventilated, ventilation is good. What is next?
And I'll give muscle relaxant, sir.
You give muscle relaxant. What muscle relaxant you prefer?
So non-depolarizing muscle relaxant, short
Non-depolarizing muscle relaxant.
Short
Preferably.
atracurium, sir, at dose of 0.5 mg per kg.
Okay, you're gonna give atracurium. Atracurium 0.5 milligrams per kg, which roughly comes 2 milligram. Okay,
2 milligram.
atracurium is given. How long you ventilate with atracurium?
Sir, 15 to 20 minutes, sir.
You're gonna ventilate 15-20 minutes with atracurium?
3 minutes, sir.
3 minutes, sir.
3 minutes, sir. 3
What
minutes.
What happened for you, right?
I thought of incremental dose.
No. You're gonna be 3 minutes, you're gonna ventilate the kid. Okay?
Yes, sir.
Right. So now ventilation is good, the baby is ready for intubation. You are putting in the scope. Okay.
Yes,
What
sir.
are the problems which can happen while in putting the scope inside?
If there is this baby has a cleft lip, sir, so isolated cleft lip, so
Okay.
there it should be less problem.
Okay. But in
if
case
the
if there is a
child-
large alveolar cleft, what is the problem?
the scope can get hinged at the gap.
Okay, it can get slipped
can-
and hinged at the gap. So
can
what are the
injure-
precautions you take?
Yes, we can keep a gauze
Okay.
in between or a dental.
All right, you can keep a good gauze, pack that defect mechanically, and then you can put it the scope again. This is particular problem when there is a left clip, okay, because that is where you're going to keep the scope on the left alveolar cleft region. So when there is a huge gap, it gets stuck in that cleft, so eventually making the laryngoscopy difficult. So when there is a large cleft, pack the defect to the gauze piece, and then you can do the intubation, right? So what
Yes.
type of intubation you're going to do? Which scope you're going to prefer?
I would prefer a straight blade, sir, Miller scope.
Okay, you're going to prefer a
Miller
straight blade, right? You have lifted the epiglottis. Okay. What size tube do you choose?
I would take tube according to the formula H by 3 plus 3.5.
Okay.
3.5 uncuffed tube, sir.
You're gonna choose 3.5 uncuffed.
And preferably
Okay.
ray tube, sir.
Okay, preferably a ray tube 3.5 uncuffed. Okay, so what is the advantage of ray tube? What is the disadvantage of ray tube?
It is a preformed tube, sir.
Okay, it is a preformed
Less
tube.
chance of getting kinked.
Less chance of getting kinked. Less chance. Okay. Less chance of getting kinked. Okay. Then
It is surgically, surgeons find more access.
so it is well away from the surgical field. Okay. You can say, okay, preferably you choose a south facing tube. Okay.
Yes, sir. Yes.
South facing ray tube. So because the circuit and the tube are away from the surgical field, so it will be easy for the surgeon to access the operative zone. Next. Okay, tell me some disadvantages.
Um, accidental extubation.
It comes in the way of the mouth gag.
Disadvantages of ray tube.
Difficult
is
to
difficult.
suction.
Suctioning is difficult.
Okay, suctioning is difficult, right? Fine. Then there is a kink in the tube, right? Naturally deformed kink, bend. So when there is bend, airway resistance will be very high. Okay, so airflow through the tube will be relatively much difficult because of the bend in the naturally formed tube. Then, most important thing, most important thing.
Accidental extubation.
No, anything else that can happen with any uncuffed tube.
Airway pressure.
No, that's what we said. That airway resistance is going to be very high. Most important thing which the examiners expect you when you tell about ray tube.
Interbronchial intubation, sir.
Why endobronchial intubation?
Peritubal leak.
When position of patient is when they put the mouth gag, it can be under.
Okay, why there is endobronchial intubation? That is the question. Why it doesn't happen with other uncuffed tubes? Why specifically with ray tube?
Because of
it-
fixed length.
Length.
Yeah, okay, so that's a key word they expect you. Okay, the tube is like this, right? So this part is going to be outside and get attached to the circuit, right? So whereas this length from the kink or the bend part to the tracheal end point, this is a fixed length. So you can't alter the length of this part. So there is a chances of endobronchial intubation very high in when you use a ray tube. Okay. So depending upon the length of the trachea, you can't manipulate this length because when you take the tube out, what happens? This bent part comes out of the teeth. Then fixing the tube will be very difficult. Okay, so being fixed length of the tube below the bent part to the distal end, the chance of endobronchial intubation is very high. Right. Okay. So this point they definitely expect you from your mouth in your examination. Okay. So
Yes.
3.5 ray tube is fixed. What do you do next? Tell what you do in your theater. That is what they want.
I'll connect it to the ventilator.
Okay,
And,
connect it to the ventilator. Is it right?
Check ventilator.
Do you put the tube and connect to the ventilator?
check air entry and
No, that's what you do regularly, right?
yes, yes, sir.
So you're gonna manually ventilate, not put on the ventilator. Okay,
Yes.
manually ventilate and check the position. Okay, what do you do next?
And auscultate and confirm the air entry.
Confirm the position. Tube is positioned, and you're manually ventilated, and I check the position is good. What is next?
Um, position the baby.
No. See, once you put the tube, what do you do?
Secure the tube with
Yes.
plastic.
See, I'm telling you, tell what you do. Other cases, I'm least bothered about these steps. But in particular, in this type of patients, I'm asking each and every step because each and every step they expect you whether doing it properly or not. Okay. So once you put the tube, what are you going to secure with the plaster, right?
Yes.
Secure the tube. In pediatrics, very important. Okay. After secure the tube, what is the next most important thing?
Check ventilator.
Check the position again, right?
Yes.
So in adults, they don't migrate, whereas in pediatric patient being given the shorter length of the trachea, even a minor movement while securing the tube is going to be endobronchial, right?
Yes.
Right, secure the tube. So check the position again. What is next? Okay, you have secured, you have checked, it is fine now. Next,
Connect to the
Connect to the
connect to the bag or
ventilator.
manual ventilator or whatever you have, right? Connected. Come fast, we're running out of time.
Yes. Then we'll adjust the flows and tidal volume on the
Okay,
monitor.
gonna
Ventilator.
maintain with the oxygen and
And
nitrous,
nitrous,
and then with the SIVO. Or
sevoflurane.
if you want, you can run with TIVA, right? Good. Maintenance has been started. Then
And then
position.
relax. Other guys, please keep quiet. So maintenance has been started. What is the next step in this procedure?
pain management, sir. I'll
No,
once
that's a long way to go. Just look yourself inside the OT and think of what you do next. You're gonna
I'll
insert the
cover
throat pack, right?
Okay.
Right? You're gonna insert the throat pack next, right? Once the tube is secured.
Yes, sir.
Yes or no? That's the
Yes,
next
sir.
step,
Yes, sir.
right? So you secure the throat pack. What is the next thing?
Um, eye protection, sir.
No. Check the position of the tube again, right?
Okay, sir.
Once you put the throat pack, recheck the tube position again. Got
Okay.
it?
Yes, sir.
So now it is the third time you're going to check the position. One is after intubation. Second thing is after securing the tube. Third time is after putting the throat pack, check the tube position. Okay. Throat pack is secured. What is next? They're going to position the patient, right?
Yes, sir.
What is the position they adopt?
They'll keep a folded sheet under the body and keep the head extended.
Okay. So head extended and shoulder roll.
Shoulder.
Okay.
And I'll check.
Position is done now. What is next?
I'll check the air entry again, sir.
All right, check the position of the tube again. So this is the fourth time you're doing. So first, second, third, and the fourth time you're checking the position after positioning the baby. Right, good. What is next step they do?
They'll keep the mouth gags, that
They're gonna
gag.
put the mouth gag. Very good. After putting the mouth gag, what is your role?
I'll check for any increase in airway pressure.
Okay, check the tubes again.
Tubes again. Check
And
air
increase
entry.
in airway pressure, right? So this is the fifth time you're doing. So in a cleft lip get palate surgery, you have to check the tracheal tube position 5 times, and these are those 5 times where you check the tracheal tube. After intubation, after securing the tube, after putting the throat pack, after positioning, and after the mouth gag is in. So these are the 5 different times where you have to check the position of the tracheal tube. Got the point?
Yes, sir.
Good. Right. So mouth gag is inserted, tube is fine, there is no increase in airway pressure, surgery is started. Right. What is your analgesia plan intraoperatively?
Analgesia, sir. Opioid. I can give opioids.
Okay, what opioid do you give?
Okay, opioid fentanyl can be given at a dose of 2 mics per kg.
2 mics per kg, which will be roughly around 8 mics. So you're gonna
8
give
mics.
fentanyl 8 micrograms. Right.
Second, I can give paracetamol at a dose of 15 mg
15
per
milligram
kg.
per kg, right? So you're gonna give 20 milligrams or 60 milligrams of paracetamol.
Sir.
60 milligrams. Don't tell about per kg, tell the dose you give, okay? So
Okay,
that will infer the examiner that you know the exact dosage, right? Per kg dosage. Telling that I'm gonna give fentanyl 8 mics, I'm gonna give paracetamol 60 milligram, then NSAIDs. What NSAIDs you prefer?
Keterol.
Ketorolac, okay?
Okay.
Ketorol. What is the dose of ketorol?
Ketorol, I don't know, sir.
It's 0.5 milligrams per kg, right? So if it is 4 kg, you're gonna give 2 milligrams of
2
ketorolac.
milligrams.
All right. So what other analgesic options are there?
Sir, per-rectal
Perrectal.
diclofenac or per-rectal paracetamol.
Okay, Perexil, paracetamol, paracetamol, diclofenac. Then
Ketamine, injection ketamine.
ketamine is a short one. Okay, fine. Let's include ketamine. Then
Intraorbital nerve block.
Local
Dexmedetomidine.
infiltration by the surgeons, right? Local infiltration by the surgeons, right?
Yes, sir.
Dexmedetomidine,
Dexmedetomidine.
either as a part of pre-medication as well as a part of intraoperative analgesia. Dexmedetomidine. Then someone told me no blocks,
Intraorbital nerve block.
infraorbital no blocks, right? For the cleft lip, if it's a cleft palate surgery, you can give maxillary nerve block, which is the part of trigeminal nerve. So maxillary nerve block by the branches are greater palatine, lesser palatine, and the nasopalatine nerves. All this comes from the maxillary division of trigeminal nerve. So I can give those blocks and give analgesia. Good. So intraoperatively, surgery is done, and right. So the surgery is going for almost 2 hours. What do you advise a surgeon to do?
I would
It's
check
still
the-
not completed. Still not completed. Surgery is almost 2 hours now.
Or remove the mouth gag.
Okay, most important thing. Ask the surgeon to release the mouth gag. Release the mouth gag, because when the mouth gag is there for more than 90 minutes, the chance of tongue swelling is very, very high. Okay, so release the mouth gag. Wait for 10-15 minutes. Give a head up posture so that the edema tends to settle down, and then you can re-put the mouth gag. Good. Now let's plan for extubation. How will you extubate this kid?
Awake extubation is preferred for this patient.
Okay,
sir.
preferably do an completely awake extubation. Then
Excuse me, sir. I just wanted to ask whether some professors do use pressure controlled mode for children, for the neonate, for the baby.
I mean, as I said, pressure control mode or volume control mode, whatever, it's going to be depending upon the person who is doing the technique. So pressure control mode, provided you could able to maintain adequate tidal volume appropriate for that age, it is fine. You can use pressure control mode. But the problem with the pressure control mode is this: you're using an uncuffed tube, right? So when you use an uncuffed tube, if there is a leak around, because naturally there's going to be leak around the tube, right?
Yes.
Which is an acceptable leak. So when you use a pressure control mode, when there is a leak around the uncuffed tube, what will be the final ultimate tidal volume? It is going to get dropped, right?
Yes, sir.
So that is why pressure control mode is not been preferred in majority of the institutes. Volume control mode, you can be used very safely.
So is there any specific advantage of using pressure
No,
control?
no advantage, nothing. Actually, it is much worse to be in as far as I'm concerned, because one is these lungs are already stiff lungs, they're not fully developed, so you need to have a larger pressure to open up. When you use larger pressure, paradoxically the leak is going to be more. You're not going to achieve the adequate tidal volume.
Thank you. Thank you.
Good. So yeah, so awake extubation. How do you extubate?
Um, I would suction the airway, sir.
Yes, good. That's
initially.
tell me what you do. Okay, put adequate suction. They're least bothered about these steps in other cases, but this type of cases, they definitely ask you what are you doing. All right, so adequate suction. Then
Keep 100% oxygen.
keep 100% oxygen. Cut off all volatile.
Cut off
Right?
all the inhalation
Right.
induction.
Yeah. Then
Remove the throat pack.
good.
Remove
Most
the throat
important
pack.
thing. If you don't
Yes.
tell that, you're gonna be horribly harassed. Right. So remove the throat pack. Don't forget to mention this one.
Yes.
Next.
Then one I will change it. If the baby was put on ventilator, I will connect it to the JR circuit and try to
Okay, you're
make
gonna
it
manually
spontaneous.
get back to the manual ventilation in the hand. Fine.
Then after checking for ventilation, I will, if the baby has started breathing, I will give injection neostigmine.
Okay,
And
you're gonna antagonize the neuromuscular blockade. Right.
with
What is the
neostigmine,
dose of neostigmine?
0.05 mg per kg, sir. I will give around 0.25.
Okay, 30 to 70 mics per kg, or you can roughly give 50 micrograms per kg. Right. So you're gonna give neostigmine plus
Atropine or glycopyrrolate can be
preferably
given.
atropine for less than
Yes, sir.
6 months kid. Okay, glycopyrrolate will not work
Yes.
as good as possible. So give atropine. So it is 20 to 30 micrograms per kg. Right. You're given atropine neostigmine. Baby is breathing well. Tidal volume is good. It is completely awake. Then what do you do?
Then I'll put the child in lateral position,
Put the
tuck the
child in the
airway
lateral
again,
position, suction the airway again,
and
then
take out
extubate,
the
take
extubate.
out the tube. Okay, good. So now you have extubated the tube, but the baby is struggling to breathe. What are the reasons for airway obstruction post-operatively?
Okay. Inadequate pain relief,
Reasons for airway obstruction
secretions,
post-op, right? Number one,
secretions,
secretions. Good.
airway edema,
Airway edema.
residual muscle relaxant, and
Good.
opioid effect.
Residual effects, anesthetic effects. Then spasm,
Laryngospasm,
laryngospasm, and lastly, bleeding.
bleeding.
So these are the 5 different reasons for airway obstruction in a baby after extubation, right? So let's discuss about the airway edema. Secretions you're gonna suction. What are the risk factors for airway edema? When you suspect the airway edema is more likely in this type of kids?
Prolonged surgeries,
Long surgeries, good. Long surgeries. Then
trauma while intubation.
traumatic intubation, right? Violent intubation, repeated attempted intubation, right? When you use an inappropriate size tube.
Yes, sir.
Okay, so these are the reasons for airway edema in the as a cause for airway obstruction post-op. Then residual effect of anesthetic agents, which will, what are the reasons? It could be residual opioids or it's because of the effects of the inhalational agents. Okay. Laryngospasm, again, very common in the post-operative period. How do you manage laryngospasm?
Laryngospasm, if it is partial laryngospasm, we can initially suction the secretions out, put the baby in lateral position,
Suction, lateral position, then
deepen the plane of anesthesia.
so deepen the plane, you can give a dose of either propofol or you can give succinylcholine. Okay. So
And
before that, what happened thing is before deepening, try CPAP. Okay, that's the most important thing. Go step by step. Suction, lateral position. Then what do you do normally? You're gonna put the mask and ventilate the baby, right?
yes, sir.
So CPAP will open nearly 95% of the laryngospasm. Right. So laryngospasm, CPAP, right? When still it is not working, you're gonna try with propofol or
Yes, sir.
succinylcholine. Good. The most recent, another treatment recently now is the chest compression. So that is one of the recent treatment for laryngospasm. What they try to do is they just give 1 or 2 chest compression and open up the spasm from other side of the obstruction. Right? If there is obstruction at the cord level, CPAP is opening from the top, chest compression opening from the bottom. So there has been good studies where it's been proven that laryngospasm can be relieved by chest compression also. Good, that's a novel treatment. Good. So how will you manage airway edema?
Airway edema.
So when there is airway edema, you should know how to manage, right?
Yes, steroids.
Nebulization.
Steroids, nebulization, you can use nebulized adrenaline.
Yes, sir.
Okay,
Yes, sir.
good. So what is the post-operative management? Post-operative things you look in there. So nursing in the lateral position. Okay.
Yes, sir. Yes, sir.
Then adequate analgesia. Make sure there is no respiratory depression. Right.
Yes,
100% oxygen for 1 to 2 hours in the post-operative period. Very vigilant for complications. All right. So when there is an airway obstruction, when you put an airway for ventilation in the post-operative period, just be careful with the suture lines. Okay. Don't try to damage that. Very careful before putting an airway or suction. Don't damage the suture lines. So post-operative again is the calm, restless, make the baby comfortable with oxygen, give adequate amount of analgesia without compromising the respiratory pattern, and make sure you prescribe drugs for post-operative nausea, vomiting. That's it. Any questions?
Sir, excuse me, sir.
Yeah.
Sir, what is the difference between a pediatric rapid sequence induction and an adult rapid sequence induction?
I don't think so. There is much difference between the pediatric and adult rapid sequence induction. But the problem in the pediatric rapid sequence induction is chances you can't wait for longer time for apnea because, as he said, they're going to desaturate very faster. So in that case, you have to make sure you pre-oxygenate the babies for much longer time than the adults. In adults, we're going to ventilate of pre-oxygen for 3 to 4 minutes, whereas in pediatric patient, you have to spend at least 5 to 10 minutes for adequate pre-oxygenation. Okay. Second thing is, here in modified rapid sequence induction, where you can partially ventilate the kid. In pediatric, it is allowed provided you keep the airway pressure less than 15 millimeters of mercury. When you ventilate, you can partially ventilate by keeping the airway pressure less than 15 such that you don't inflate the stomach. Okay. Another thing is, during the pre-oxygenation, the apneic oxygenation has to be utilized to the maximum, where you can give 15 liters of oxygen during your apneic time, because the oxygen flow through the lungs goes by diffusional process. So that you can maintain the oxygenation for quite longer time. That's the only difference.
Okay, sir. Thank you.
Excuse me, sir.
Yeah.
So how different is the ventilator setting in a pediatric child? I mean, pediatric patient.
The
compared to
problem
an
is
adult?
when you use an uncuffed tube, it is very, very difficult to put the patients on the ventilator, mainly because the leak is not compromised by the ventilator. Ventilator will feel that the tube is not in proper position. It cannot compromise for the leak. So you have to use an appropriate tube, not a larger size tube, not a lesser size tube, such that there is an allowable leak. Okay. So at that tube, the problem is, for example, if you're setting a ventilator for a tidal volume of 10 ml per kg, right? So the baby is 4 kg. If you set a 40 ml tidal volume, when you use an uncuffed tube, which is of inappropriate size, what is the problem? It is going to deliver only 20 ml because of the leak. So try to use an appropriate tube, which is allowing an allowable leak around the tube, and try to ventilate, keep the setting at around at least 15 ml per kg, such that you reach a tidal volume of 10. That is the point. But preferably, when you tell in the exam, you can tell that less than 1 year kid, you're gonna manually ventilate the kid, not put them on the ventilator. Okay, that is a safer answer. Got the point?
Yes, sir. We
Yes,
can't
sir.
use an cuff to tube.
You can use a cuff tube. That's why I tell. So one is technically, in older school of thought is, when the kid is less than 8 years, they said that you should use only uncuffed tube. But the current school of anesthesia is, when the baby is fit enough to use more than a 4-size tube, right? When the babies have the capacity to hold a more of 4-size tube, we can use both uncuffed as well as cuffed tube. There has been a huge big study which has been conducted examining 20,000 kids. They found that when you use a more than 4-size tube, irrespective of whether it is a cuff or uncuffed size, the chance of post-operative respiratory obstruction is very minimal. Okay. But when you are facing a kid where you're going to use less than 4-size tube, that time you use only uncuffed tubes. Okay. Any other questions?
Sir, if after inhalational, you said like we have to inhalational agent, we have to put and we have to secure an IV access.
Yeah.
What if I fail to secure an IV access and patient went into spasm suddenly? Can we tell like I will go for giving any IM drugs?
You can say, if the baby is gone for spasm, right? What happens? There's no choice. You have to deepen the plane with the sevoflurane. That's the only choice left, right? Or you can give intramuscular succinylcholine as a rescue option.
Okay, sir. Thanks.
All right. Shall we stop here?
Sir, shall we have to know about embryology of palatal growth?
You want to know the embryology of the palatal growth, right? Okay, let's have a short discussion, right? So there are basically 3 processes, right? Right. So this is the frontonasal process. This is going to be the maxillary process, and this is going to be the mandibular process, right? So when the future lens nares are formed, which is called as the nasal pits, okay? When the nasal pits are formed, what happens, there will be a depression like this. So this will divide into, the frontal nasal process gets divided into median nasal and 2 lateral nasal process, as there is a cleft which is formed here. This is one lateral nasal process. This is going to be the other lateral nasal process. So this median lateral process and the lateral nasal process join to form the upper lip on both sides. When there is failure of the fusion of median nasal process with the lateral nasal process, that becomes the cleft lip. Okay, so failure of the frontonasal process with the maxillary process results in the cleft palate. Okay, so again, if you see the palatal formation, right, it is like an Y shape, and this is called as the incisive foramen. Okay, so before incisive foramen, it is called as the prepalatal structures or the primary palate. Behind the incisive foramen, it is called as the secondary palate. All right. So when there is failure of the fusion of secondary palate, you get the cleft palate here. When there is failure of fusion of the maxillary process along with the secondary palate, you get the complete cleft palate like this. Bilateral cleft palate is like both sides with a premaxilla hanging separately. This is called as a premaxillary structure. Okay.
Thank you.
Got it. Excellent. Thank you, guys. Let's stop here.
Thank you, sir.
Thank you very much. Well done, Dr. Nishu. Very good.
Thank you, sir.
Yes, sir.
Next class.
Next class probably this weekend. All right, Saturday.
Okay, sir.
Thank you, sir.
Thank you.